Okay, well, welcome to the 5th Centennial Lunch and Learn at the Johns Hopkins Bloomberg School of Public Health. I'm Karen Thomas, the school historian, and I have a really fun talk for you today on the history of technology and computing. I'm going to start by putting out some ideas from some of our faculty in the past about how they viewed technology in public health. And then I'm going to look at the history of computing, which has been absolutely essential in the history of this school. And then I'm going to look at the history of technology, particularly in the basic sciences, and look at how that developed. And then I'm going to wrap up by showing how computing and technology really, or computing and basic sciences particularly, really couldn't have evolved one without the other. And today we have these enormous terabytes of data being produced on a weekly basis by some of our research, and we are very much in the 21st century with the volume of data that we produce. But let's go back to the very beginning of when we were first using punch cards. So the questions I want to look at is to just identify some of the most important tech and computing developments at the school, look at especially how computing really originated in public health and medical records in many ways, and then finally talk about some of the tensions and challenges with this explosion of technology in public health, because it definitely has not been a smooth upward road. So many, if not most, public health professionals have traditionally viewed technology as a major engine of progress in public health. They have had very positive attitudes toward technology. And the first that I'll mention is William Sedgwick, who wasn't at our school. He was at Harvard. He was a sanitary engineer, and he also worked for the Massachusetts Department of Public Health in the early 20th century. And as an engineer, his approach to public health was that it was really an interdisciplinary field that was combining the best of engineering and medicine to fight disease on a mass scale. And so Abel Woolman and Cornelius Cruzet, who were both sanitary engineers here at the school, talked about the importance of this intermediary position between medicine and engineering, which they said in 1957, the need for this intermediate position is greater than ever before. It creates a hybrid attack on the problems of modern technology and the effects of that technology upon man. So it's important to note, they said the problems of modern technology. So modern technology is creating enormous amounts of pollution and injury and other problems, but they still see good technology as the solution to the negative outcomes of technology. So they really continue throughout their career at the school. Woolman was in sanitary engineering and taught here as a lecturer from the late 19-teens, and then Cornelius Cruzet came in shortly after World War II, and they both stayed until the 1980s. So they championed the classical concept of building public health on permanent environmental alteration using technology. So again, they're saying that yes, there are problems with the byproducts of civilization, but that doesn't mean you just throw technology out. It means you use good technology and new methods to deal with the old problems. So an outgrowth of this, and I've mentioned Sue Baker before, is that Sue Baker, who was the founder of the Injury Prevention Center here at the school in 1987, and has been on the health policy and management faculty since about 1971 or so, she was really coming at this, I think, from an engineering perspective, which is very interesting because she wasn't herself an engineer. But she said that mechanical and thermal energy are the greatest contributors to injury. So this is definitely a downside of technology. When you think about what you might call planes, trains, and automobiles, this massive mechanical energy that's at the heart of our transportation system and makes so much of our 20th and now 21st century lives possible, it also creates this enormous source of injury. And she, like Woolman and Creuset, are saying the lack of application of our technical knowledge and the lack of evaluation have been major deficits in the field of injury control. And, so she comes back and says injuries are the #1 source of loss of productive years of life. So Woolman and Creuset and Sedgwick had all applied sanitary engineering technology to mainly purifying the water supply. And by doing that, diarrheal diseases such as typhoid dropped, I think, 40-fold between about 1920 and 1945. So they are addressing infectious waterborne diseases, whereas Sue Baker is addressing injury, which often results in chronic disability. So she's saying that this loss of productive years of life can be greatly reduced by modifying the physical environment. And many people in the health, behavior, and society group might disagree with this, but she says it's easier to do that than to modify human behavior. And so if you look at the seatbelt as an example, seatbelts were in cars beginning in the mid-60s. Nobody was using them. It's not until you pass laws and introduce car seats, but especially when you get the airbag, that you substantially begin reducing fatalities and injuries in cars. So that's kind of where she's coming from. So the picture on the right here is what I find a very disturbing picture. It's of a man in Iran in 1950 spraying a child on the back of the neck. He's dusting him with DDT powder. Okay, so this is to prevent louse-borne typhus, which was a serious problem, and DDT was considered the magic bullet against all sorts of insect-borne diseases, and it was used extensively in the mid-20th century. And many of the faculty here at the school, particularly one of our graduates, Fred Soper, who becomes director of PAHO, the Pan American Health Organization, they really pioneer vector control methods using technology, swamp drainage, both aerial and ground application of DDT. So they are taking technology to new levels and using it to fight disease on a mass scale, just like William Sedgwick wanted to do. But of course, we find out later on that there are also major drawbacks to spraying people with DDT. Rachel Carson and the environmental revolution in the 60s and 70s kind of take that in a different direction. But for now, and by the way, this photo appeared as a publicity photo in a World Health Organization brochure. Okay, so this is like the wonders of the new technology. Check this out. So I want to point out that technology occupies this interesting intersection in public health between high technology medicine and the idea that public health must do more with less. Our interventions have to be low enough cost and easy enough to implement that they can be done so on a mass scale and for a long period of time, okay? So we are different than medicine. We may not be able to do extremely, extremely expensive, for instance, coronary artery bypass surgery is very expensive and intervenes on individuals, and that's not a public health method because it can't be done economically and effectively on large populations. So Elizabeth Fee, the first historian of the School of Public Health, has said that high-tech medicine with both exciting and lucrative and the growing economic power and resources of academic medicine with all this great new technology and surgical techniques and magnetic resonance imaging and things like that, That contrasted with what she calls the relative and sustained poverty of public health. So in public health practice, in agencies, and also in most schools of public health, the budgets were very tight and they really had to make do with what they have. So keep that in mind as we're talking about a lot of the technological innovation at Hopkins, because we're unusual in that we have more resources than most schools and agencies do. So again, looking at this photograph, Carl Taylor, who becomes the first chair of international health at the school in 1962, critiques all of these very, I would say, hot and heavy vertical style disease eradication campaigns that were really one-shot methods, okay? You inject someone with penicillin, or you spray them with DDT, or spray their house with DDT. And this is what he said about those methods. He says they were organized as quasi-military campaigns with narrowly focused short-term objectives, strong hierarchical control, meticulous rigor in details of implementation, a limited range of technical interventions, like I was saying, the one-shot methods, little field flexibility, and more concern about accommodating mosquito ecology than human social and cultural constraints. People weren't consulted, their compliance was taken for granted, and the technical experts in government was in control. Okay, so that's his critique of some of these methods, and he has a lot of grounds for that critique. And he really becomes a pioneer in not only, now Carl Taylor doesn't brush aside technology. He is one of the people who did research on the IUD as a really good low-cost method of family planning. But this tension in technology is partly about whether we use these very technologically oriented vertical methods in public health, or do we also, and I think it's not an either or, but an also and, we also have to use horizontal methods of planning and implementing public health interventions that will strengthen the overall infrastructure. Okay, so that those vertical campaigns and those individual disease eradication efforts can be more successful in the long run if they have a strong public health infrastructure to support them. So let's move now to computing, because early, and I would say, we're really talking about calculation and just simply counting things in the late 19th and early 20th century. But computing and public health have very close intertwined origins. So in 1879, the physician John Shaw Billings creates Index Medicus and the field of modern medical informatics. So John Shaw Billings has a couple of Hopkins connections. He is the one who designed the original Johns Hopkins Hospital building, the famous dome that's the medical school's logo. So he is the medical librarian for the US Surgeon General right after the Civil War. So he is really an amazing guy who pioneers using, he's cataloging not only research and educational information for physicians to be able to refer to, but also he is cataloging medical records and patient data. And that's one of the outcomes of the Civil War, is that you have a huge number of Civil War veterans whose records must be kept in order to give them their benefits and provide them care. And so that goes on into the 20th century. So this tremendous need for the veterans' medical records prompts Billings to create these new methods. So one of Billings' associates is a man named Herman Hollerith, and he goes to work in the US Census. And the school has always had a very close relationship with the US Census Bureau and the vital statistics and morbidity and mortality statistics bureaus of the Public Health Service. And that function in collecting vital statistics actually gets transferred from the Census Bureau to the Public Health Service. I think that happens in the 30s. So the Census Bureau, for the first time in the census of 1890, and this is after there's been a tremendous increase in immigration into the United States. So there's more people to count than ever before, and they're coming from more diverse backgrounds than ever before. So it's a very difficult data collection problem. And so Hollerith uses and invents this punched card tabulator that's based on some prototypes that he had when he was working with Billings in the Surgeon General's office. And his machine, which is pictured up on the right, reduced the time for calculating the census from 8 years, so almost till the next census, to 2 years. And that is revolutionary. That's absolutely the beginning of not just health informatics, but of modern computing in general. So until the mid-1950s, these analog paper punch card systems are how IBM, International Business Machines, gets its start. So Hollerith is directly involved in what becomes IBM using these kinds of methods. So it's an automated, it collects the cards and it sorts them based on holes punched into the card that signify different categories of data, such as sex, age, et cetera. So in 1918, when the school opens for its first classes, the Monroe-matic calculator on the left, which you may have seen on display on the first floor across from Sheldon Hall, every student at Johns Hopkins, at the School of Public Health, learns to use these calculators. And they do it to understand vital statistics and biometry, which is the original name of the Department of Biostatistics. And it's Lowell Reed, who's the chair of vital statistics after Raymond Pearl, who renames the department of Biostatistics in 1930 to reflect that this is not just about counting births and deaths and sickness. This is about the whole realm of biology and medicine and public health and science. So it must be called biostatistics. And that starts here. So we have the first Department of Biostatistics in the world. And we have the second department of any type of statistics in the world. So the only one before us is the Department of Statistics at Cambridge University in England. So in the 1930s, the Johns Hopkins Hospital becomes a center of medical informatics, and two biostatistics faculty, Carol Palmer and Edwin Crosby, who also is the director of the hospital, create this medical records system that enables you to do research and ask questions of patients' medical records in the aggregate, okay? Because remember, this is still the era of paper, handwritten, often scrawled charts. And they create the first system that really begins to allow medical research for clinical trials and all types of research to be done. In 1938, I've mentioned Raymond Pearl in a previous lecture, and in 1938, he does a study on 7,000 individual patients and looks at their medical records and finds out when they died and what they died of. And 7,000 was just an unheard of number. Medical articles were being published into the 1960s that only used single digits. They were just observations of this many patients in my clinic did this. So Raymond Pearl using 7,000 people is just astronomical. And he does it by using these types of punched card data calculators. And it enables him and every public health and medical researcher after him to make statistically significant observations and conclusions about the research that they're doing. Okay? And I love this advertisement for the Monroe calculator. You can see so this advertisement is from 1957 when it's still being used. it has this little circle around the name Monroe on the lower right. You notice it looks a lot like an atom because it's 1957 and it's the atomic age is in full flower. So the space age, you've got the planet back in the background. So I just really love the iconography of that ad. So in this slide, we have mainframe computers with the reel-to-reel tapes. And so in 1946, Halbert Dunn, who's the chief of the National Office of Vital Statistics, who works very closely with Lowell Reed on the statistical studies in the Eastern Health District here in Baltimore, Halbert Dunn published, this is the first article on record linkage in the American Journal of Public Health. So although the idea of record linkage, when you go on Amazon and your individual customer record and all those many possibilities that you can click on to buy on Amazon, that's a form of record linking. Record linking is everywhere now, okay? The internet has made record linking like a whole new universe. But it starts in public health, and this school is really at the very beginning of that trend, and the faculty here are using record linking to match the basic demographic data of people in the Eastern Health District with their clinical records from local physicians and the Johns Hopkins Hospital, and public health department records from public health clinics. So outpatient, inpatient, demographic records, it helps us understand the socioeconomic determinants of health. So all of this work in record linking is being done very early on in the 40s and 50s in the Eastern Health District. So we're going to skip ahead to 1978, and I wish Jim Tanasha had been here with us today, but he'll have to watch the video. Jim Tanasha is a giant in this kind of research, and he is really one of the key people in the history of the school, and I write about him in the book, in advancing public health computing and teaching other people how to do that. So in 1978, he introduces this new course, Problems in Data Analysis, which served, has anybody in here ever used SPSS? Okay, it's the statistical package for the social sciences, and social science is very data intensive because you have enormous amounts of survey research, but those computer programs are adapted for many other purposes, including public health, and of course social science is also on the rise during this time in public health as well, so we're doing our own survey research that creates large amounts of data. So Tanasha's students are the one who help to debug and test this software and develop new versions of it. And it's a mainframe program for batch processing data and we're still using punched cards at this time until about the early 1980s. So when students did their dissertation research, they would bring boxes of punched cards, like big boxes like this, and they're all lined up, hundreds and hundreds of them, to the card reading machines that were located on the second and third floors of the school, and they would line up, because everybody was trying to do this, and there were only a teeny tiny number of computers in the whole school. So they would read in their jobs. That means they manually fed the cards into the machine, okay, and you had to hope to God you did not trip and fall, because then that would get them all out of order, and you would be totally out of luck. So the next morning, they would go and get their printouts that were these like dot matrixy, weird-looking little printers on green and white striped paper, and they would get it at the mainframe over in the Turner building at the medical school across Monument Street. And so David Celentano told me, because he was a student here in the late 70s, he said, you know there was a problem when your printout was only 3 pieces of paper. The job had failed because you left out a semicolon or a comma. So it was a very exacting way to do research because there was absolutely no room for any kind of error. So I would go 2 weeks sometimes without getting anything done because I kept having these teeny tiny little errors where you left out, you inserted a space or a comma or something where you shouldn't have, and it was just maddening. So that was the mid-century public health computing. So the school played a key role in developing the National Death Index. So yes, that's a police reference there, Ghost in the Machine. But so in the early 1960s, Alan Gittleson in biostatistics is pioneering the use of these automated processes. And what he wants to do is analyze multiple different types of records, not just in somewhere like the Eastern Health District, but like on a statewide and national basis. He wants to really connect the dots together in a whole new way. He wants to analyze data on a systemic basis, and it will, enormous volumes of data over many years with hundreds of thousands or millions of people, okay? So the methods that he developed, so this is an IBM 7094 computer, which is what he was using in the 1960s to do this kind of work. And it would cross-reference the different type of vital records, and these are the kinds of things that you could do with it. If you looked at how many people, how many babies had been born, say, in the state of California, and then cross-reference that with infant mortality, you could begin to see patterns in the data of what are some of the causes of infant mortality, or what are some of the groups, what are the demographic groups or geographical groups where infant mortality is really on the rise. You could also look at the mother's maternity records, and then the birth records for the babies, and then their siblings, and you could connect all that information together, and it gave you a whole new window, especially on hereditary disease, but also on the results of pregnancy complications, which, as I said in a previous lecture, were very important in determining developmental disability. So we had never before been able to do this kind of research of connecting this many different factors together in a, again, statistically meaningful way, not just haphazard guesses, but based on hundreds of thousands and millions of patient records, and really understanding the prevalence of disease and the connections among different types of disease and conditions. So this was called frequency tabulation. So in 1982, to kind of give you an idea of where computing was in 1982, he thanked the school's faculty and graduate students for what he called the impossible task of processing 3 billion bytes. That's 3 gigabytes of data. So that is how much data was in 21 million death records that he analyzed from 1968 to 78. So that was the original National Death Index. And that continues today and is connected to the Medicare and Medicaid databases, and our faculty continue to use these interconnected databases for, I can't even describe how many different things they do with it, but it's absolutely essential for the work that we do today. So to look a little bit at what people were learning about computers at the school in the 70s and early 80s. So up on the right, in about 1983, the school bought an IBM 4331. Its entire storage capacity on that great big computer was 500K. Okay, that used to be like, when I was in college, that would be like a floppy disk. So in 1977, so I was looking at the school catalogs, and they begin to have these little notices up in the front that says, hey students, you really should consider possibly taking a computer class. And they say, both the administrator of public programs and the research worker will finding it increasingly desirable to understand how to use computers. There were no individual terminals. I described the process by which you had to do research. And there were only 3 shared terminals that is where you had to get in line and feed in your cards and everything, in the whole entire school at that point. So the courses you could take, you could do computer data processing in healthcare organizations. So in health services research, this is very, very useful methods for people looking at health systems and patient data. You could also use it for operations research, computer analysis of decision models. So operations research had a foot in both biostatistics and what's now health policy and management. And then problems in data analysis was a course that Jim Tinashe created, which I mentioned earlier. And then this was the worst course I ever took in college, was Fortran programming was offered. And if you want to go crazy quickly, try to learn Fortran. I did not like Fortran, but that was the main. Pardon?
Who taught it here in the school?
Well, it was a non-credit course, and I honestly don't know who specifically taught it. But different departments sort of had their own ad hoc tech squads to help people make it. So in biostatistics and epidemiology, Alan Gittleson and Jim Tinashe were definitely at the top of doing those kinds of things. So by 1983, we were telling students the inability to use computers is becoming a form of illiteracy. And we go from these great big mainframes to we now have microcomputers, so the individual terminals, which are like the IBM 386 and 486 and those kinds of things. And you were still having to type in command prompts for everything. We didn't have Windows yet, so you still had to sort of know the language and know the secret password to be able to write a computer program. So the Hygiene Computing Center was established in the early 1980s, and it began to more formally offer short courses and assistance in programming and statistical software. And the MPH began to require a course in basic programming at that time. So more and more departments in the school are using this statistical software that Jim Tinashe's students had been helping to pioneer. So that's what's going on in the early 80s. Now, one of my favorite stories from the book is microwaves in Moscow. So in 1953, the Soviet Union began beaming these low-intensity microwaves at the US Embassy in Moscow, and we didn't know about it. And by 1976, suddenly the intensity of the microwaves goes way up. Like, not so much that it's gonna like fry anybody at their desk or anything, but there's a noticeable increase. And apparently, at some time previous to that, the US Embassy had caught on that the Soviets were bombarding the embassy building with microwaves. So they actually put these special screens in all the windows in the embassy to screen out the microwaves. And I talked to a friend of mine who's a diplomat, and he said, yeah, they were just kind of messing with us. They did all sorts of things that they weren't going to hurt anybody, but they just were kind of like, yeah, we're going to beam you with microwaves. So, but the Senate Foreign Relations Committee didn't know that. We didn't really know what microwaves could do. If you saw the movie American Hustle, you saw Jennifer Lawrence's character with her big new microwave in like 1976 or whatever, and she's saying, these things, like I've heard that they might like, cause cancer or something. I don't know if I want to use this. So they created this subcommittee to investigate whether this long-term, very low-level exposure to microwaves had possibly caused health problems for the Moscow embassy personnel, and it's important to know, possibly even their unborn offspring, who might have been born back in the States after they got back. So they go to the experts in radiation health and large-scale clinical testing, and that's us. So Abe Lilienfeld, Charlotte Libauer, and Susan Tinashe in epidemiology examined 13,000 State Department employees and their families, And some of them were controls who were stationed, for instance, in Eastern Europe or some other place nearby to figure out if, is the Moscow group different? Are they having different health problems? Or if they are having health problems, is this something that might be caused by other things in the environment in that part of the world? So Jim Tanasha directs the data analysis of death certificates, medical records, and health questionnaires. So they did individual interviews with the people. And he wrote 150 computer programs in 8 months. But keep in mind that a computer program then would be much, much shorter. So it's not like he's writing, I don't know, Microsoft Word in that amount of time, but it's still a huge accomplishment. And so he prints out a 12-foot stack of 8,000 pages from that giant mainframe computer, and they say, guess what? It didn't do anything. Absolutely no statistical significance between the control group and the Moscow group. So more recently, I got an email recently from Fernando Pineda, which I wish he had been able to come, but I don't see him here. So he, in 2007, establishes the Department of Biostatistics High Performance Scientific Computing Core. And that unit, part of which is actually housed in the basement because it outgrew its facilities in biostatistics, that's absolutely essential to much of the research that the school does today because we simply need space to store all the data. We've gone from, what did Alan Gittleson say, like 3 billion bytes of data. We're now producing, so the Wendy Clagg Center and Danny Fallon's research on neurological and genetic disabilities in children produces something like a terabyte of data a week, okay? So with the scope of the school's work on genomics, which I'm going to get into in a minute when I talk about basic science, all of these types of research just create enormous amounts of data. So it's this unit that stores much of the big data that we're now producing. So I would direct you to a recent article, just came out this month in Scientific Computing, titled Pioneering Green, Dirt Cheap Storage for Life Sciences Research. And this fits nicely into some things I put out at the beginning of the talk. We're at the intersection of high-cost, high-tech technology and trying to do more with less. And so he's done it. That's exactly what he's done with this. He says, you might not think that state-of-the-art storage technology is something that happens at a school of public health. Well, we have to do whatever's required to get the science done. And we had to figure out how to build very low-cost and high-performance storage for our computing cluster to support all the things that I was just mentioning. So I think, this group is a great example of this is what we want public health technology to be. So the next section of the talk is on basic science, and Brian, I stole your idea. Me and my microscope. So here's all the different people with their microscopes over the history of the school. So going from top left to right, we have William Welch, and then John Hanks in the white lab coat and several of his students in the late 50s. And then next is, can't remember her name right now, a student of Robert Hegner's in the 1930s doing parasitology research. Then Lloyd Roseboom on the right in his World War II uniform, who used a microscope to identify mosquito species. So he was like the world's expert on medical entomology and was here at the school for about 50 years. Then on the lower left, we have Brad Sack with his super groovy Abraham Lincoln beard with his microscope, and he did work on cholera and oral rehydration therapy, and as well as cholera vaccines. Then we have Art Dannenberg in the Department of Environmental Health Sciences, who worked at the Center for, and I believe still does, he's still in the faculty, worked at the Center for Alternative to Animal Testing. And then the color photograph is of Kirti Shah in MMI, who did work on the HPV vaccine. And then finally, we have parasitologist Clive Schiff, also in MMI. So, you know, the microscope, like our basic science departments just wouldn't be here. I mean, the microscope has been, you know, if we're thinking about symbols for the school, a microscope is certainly like a major symbol for the school. So let's talk a little bit about how this has changed over time and what's it allowed us to do. So in the 1930s, so electricity and better engineering and optics, especially optics, are key to these changes. So in the 1930s, you get the ultracentrifuge, which allows you to separate out the product of chemical reactions at a much purer and, you know, it's spinning around very, very, very fast, and it throws the product out to the sides, and you can, it's much more, high quality, high purity research that way. And then in the 1940s, there's something that's absolutely revolutionary for all of basic science, which is the electron microscope. So it's invented in the late 30s and then really comes into use nationally and internationally in the 1940s. And one of the main areas that, main places that pioneers the electron microscope in the United States is the Rockefeller Institute for Medical Research. And because the school has such a strong connection with the Rockefeller Foundation, many of the scientists who use the electron microscope at the Rockefeller Institute come to the school as faculty right after World War II. One of them is, he goes to the medical school first, and then he becomes chair of what's now MMI and was then called parasitology, Frederick Bang. So Frederick Bang is a cellular biologist and also has studied malaria and tropical diseases, and he served in World War II and, you know, goes to the Philippines and exotic places to study tropical diseases. And he comes back and he introduces the electron microscope to the School of Public Health. And at that time, the medical school did not have an electron microscope. So there are people coming from all over the medical campus to use Fred Bang's electron microscope. So a picture of the electron microscope, this is Barry Zirkin, who's now in BMB. This is a 1972 model of an electron microscope that's still in use here at the school, and he has named it Molly. But you can see like what a cool space-age rocket-looking thing it is. Whereas the Zeiss microscope on the left, that's the type of microscope that would have been used in labs to teach students how to examine like parasitological specimens and things like that. So the key thing that happens, just in a very simple way, is that the magnification and the power to visualize very, very, very small things increases exponentially. So in the middle this is an electron micrograph, so a photograph taken with an electron microscope, and the magnification is 100,000 times. And it was taken for Noel Rose's autoimmune disease textbook. And it shows the myelin sheath of the spinal cord and neuropathy. And so the very close together stripes in the center of the picture are the normal tissue, and then the further apart is where it's basically started to kind of unravel. So the electron microscope is able to show that level of detail. So that's just a very quick look at what the impact of the microscope at the school has been. Another cool techno thing at the school was the flame photometer. The one pictured on the left it uses like a real open flame, okay? It basically vaporizes the material that you're examining, and that emits gases. And by passing lasers through the gases, it measures what kind of light spectrum is being emitted, and it identifies information about the substance that tells you what it is and how it's composed. So that's a very layman's explanation. I'm sure someone else could do a better job. But so that's the one that would have been used in the 1950s. And then the one on the right is an atomic absorption spectrophotometer. And we use those in the school still today. And Val Collada in BMB told me about that. So what this type of equipment does when it begins being used in the 50s is, so in what was then the Department of Biochemistry, chaired by Roger Harriot, he with his faculty, Saul Goodgall and Stan Rupert, they demonstrate that enzymes activated by visible light were able to repair damage to DNA. And that is huge. That is one of the discoveries that paves the way for the fields of DNA repair. Like much of what BMB does today is about genetic damage and repair, and what causes that and what can possibly reverse it. So light-activated DNA repair after the 1950s becomes one of the major emphases of this department. So closely related to biochemistry was the Department of Radiological Sciences, which was created in 1961 by Russell Morgan, who was head of radiology at the medical school and hospital. But he defects, to use a good Cold War term, he defects from the medical school and comes to the School of Public Health because he has been, before he came to the medical school in radiology in the 40s, he was with the Public Health Service. And he was very interested in the health effects of radiation. So that field World War II is a huge catalyst because, of course, you have the atomic blasts that end the war with Japan, and you have science and doctors coming from all over the world to work with the Atomic Bomb Casualty Commission to study the effects of that radiation on the people who lived close to the blast and their children. So many of the people at the school in the 1950s and into the 60s worked with the Atomic Energy Commission, with Oak Ridge Laboratory in Tennessee, out in Nevada, all of the different major atomic research sites were using cutting-edge biostatistics and computing methods in their research, and they were also very interested in public health. So we create this new department in 1962, and it is truly the king of technology. It brings all sorts of very high-cost, high-tech toys or instruments into the school, and in fact, they have to build an entire new wing just for radiological sciences. So just one division of the department, the radiobiology division, their space goes from 2,000 before the new wing to 8,500 square feet, and they're taking up 2 floors. And the kinds of techniques that they're using are things like photochemical analysis and proton magnetic resonance. So they have very strong ties to Henry Wagner and the nuclear medicine group over at the hospital. And Wagner actually has a joint appointment on the radiological sciences faculty and is here at the school until the mid-1980s. And the department gets started at the School of Public Health in part because the medical school isn't awarding PhDs at that time, and we are. And also, we had the space and the grant money through the Public Health Service, which wants to really increase the research on radiological effects on health. So that's how that originates. So they use Geiger counters, electrophoretic equipment, and look at the price tags on this stuff. This is $1962. So I don't even know what some of this stuff is, but rotary dispersion polarimeter, analytical ultracentrifuge, time-lapse cinematography, electron microscope. So they are using optics and so spectrometry. I do know what that is. It's using the type of light emissions from either a chemical reaction and looking at the atomic level at what's going on when you expose a substance to light or to radiation. So that's key to the kinds of experiments that they're doing. So one of the main types of research they do is how radiation damages cells and what it looks like when cells begin to repair themselves. So they are using this high-tech equipment to visualize on a molecular level the actual process of healing in cells, which is, I think, quite fascinating. So I'm going to end here and just pick up a few threads of what we've gone through, because we've moved quite quickly. So some of the most influential technological developments at the school, biocomputing. Biocomputing has been enormous here, and we have been very much at the center of developing that whole field. And that has very practical applications for frontline public health agencies, for tracking trends, and now we can really do it in real time. We can use real-time data to understand when a flu epidemic is occurring, or if some substance may be causing birth defects in a population, or things like that. So biocomputing has certainly been a major one. Electron microscopy and just the application of kind of space age and atomic age ideas and technology to basic science, I think is another big piece. Something that I did not get into, but is very, very important. I mentioned Barry Zirkin and his electron microscope. So he's in the division of reproductive biology, which is now in BMB. But he originally, and that division was originally in the Department of Population Dynamics. And reproductive technology has been another very important field that this school has been very involved in, such as the development of the IUD, understanding the reasons why, on a molecular level, both men and women are either fertile or infertile, understanding both the effectiveness, but also some of the possible negative health effects of different types of contraceptives. The school has been doing all of those things since at least the late 60s, early 70s. How did computers become central to the development of 20th century public health? Computers in public health have developed alongside one another, and one of the reasons public health is so incredibly powerful today is because of its strong adaptation of computers. Public health just wouldn't be what it is today without computers. And finally, how can the school's past experience with technological innovation help us use technology more effectively? I think going back and thinking about what both Woolman and Creuset said, as well as what Carl Taylor said, is a good way to answer that last question. So I would really agree with Woolman and Cruzet that the need for that middle position between medicine and engineering that public health occupies, that it was true in 1957 and it's true today. That need is greater than ever before. Engineering has a specific set of methods and ways of thinking, and medicine has its own ways, but public health integrates, and the sum is, it's greater than the sum of its parts when it's applied in public health. Public health is also, as I talked about with Fernando Pineda's work, at the intersection of these very high-cost, NIH-funded supercomputers and electron microscopes and atomic resonance stuff, but we have also always had a very strong tradition of doing more with less and developing technology that can be used on the ground very effectively and efficiently by people who want to improve their own health in their communities. So some examples of that are this 45 RPM record from the Center for Communication Programs was the first use of pop music to promote public health messaging in the mid-1980s. And Elaine Lebrique's cell phone from about 1990, using cell phones, which, a cell phone is an example of you can go from one end of the spectrum to the other. A cell phone used to be incredibly expensive and completely out of reach to the average person. And when Elaine Lebrique had that cell phone, it cost like $1,000 or something. But now, everybody, or many, many people in the developing world have cell phones, even if they don't have electricity. Developing ways to adapt to this technology as it changes and as it disseminates out into the population is a key part of what our school has done in the history of technology. And finally, Carl Taylor warned us that it's very, very tempting to be, one person used the word seduced by these new technological innovations that are going to change the world. And we certainly have changed the world with many of our technological innovations. But Carl Taylor would say, watch out, because you don't know what the long-term consequences of some of those are going to be, such as DDT. And also, you've got to ensure that there is justice and equity and a strong public health infrastructure so that everybody can get basic preventive and primary care, or those technological innovations are not going to last very long or be very effective. Thank you very much. So do we have any questions? Yes?
What did Rod Taylor say, the quote you have from Rod Taylor, the quote that you have that he was saying that we should have these horizontal programs?
Mm-hmm. Yeah, that's at the very beginning. It's the very beginning of the, right. So this is in, it's in a later writing of his. It's in like the 1990s. It was published in the 1990s. And he's looking back. I'm sorry, the question was, when was this quote from Carl Taylor written and what was the context? So he was saying in the early 90s, so Carl Taylor was a pioneer in the field of primary health care. And he, at his research site in Narangwal, India, he did some of the very earliest research to show that providing packages of services of combining nutrition, family planning, and primary health care services together as a single package could be a very cost-effective and efficient way to improve health outcomes, especially in the developing world. So he was writing this looking back over many decades of the history because the WHO malaria campaign started in 1955, and there were earlier campaigns before that in the late 40s and early 50s. And so those campaigns started out so optimistically, and they believed in that technology so much that Fred Soper said in 1947, malaria is going to be gone in 10 years. We can do this. We have the technology, like that opening of the $6 Million Man used to say. And Carl Taylor was looking back about half a century later and saying, no, we couldn't eradicate malaria in 10 years. And once those one-shot methods kind of played out, when the Jeeps ran into the sand and the mud and couldn't get out to the houses to spray, and when political unrest disrupted the campaigns, and when there were wars and refugees going over national lines and making it impossible to track the progress of the malaria campaigns, all of those things pointed to the importance of compliance with, of getting the consensus of the people that you were doing these campaigns among and their full buy-in, and also about the social, political, and cultural constraints of being able to do those kinds of interventions, because one size did not fit all. Something that worked in the southern United States before World War II was not necessarily going to work in Africa in the 1960s. Any other questions? Thank you very much. Enjoyed it.